Together we create possible. Together we create possible.
Welcome to the Young Epilepsy podcast, where we discuss important topics that are important to children and young people living with epilepsy. I'm your host, Cameron, the Youth Engagement and Participation Manager at Young Epilepsy. Before we start, we'd like to take a moment to thank our supporter. For over 25 years, Nutricia Ketogenics has been dedicated to supporting patients with drug-resistant epilepsy. Their extensive range of ketogenic medical foods is designed to simplify the ketogenic diet for both adults and children living with epilepsy, as well as their families. For those with refractory epilepsy, a ketogenic diet can offer a promising path forward. Our supporters do not influence the Young Epilepsy podcast. Creation of topics, guests and questions are completely led by Young Epilepsy and our community. Welcome to today's podcast, Transitions into Adult Care. We're recording this podcast at the 15th Annual Research Retreat. For more information and resources to help with transitioning, please head to Young Epilepsy's website. You can also check out the links in the show notes. My lovely guest, would you like to introduce yourself?
Hi, I'm Sacha. I'm a Youth Voice Network member and I'm 26 and I'm studying to be a nurse.
So I'm Amit Bali. I'm a doctor, so a paediatrician. So I'm a consultant in London at Barts Health with an interest in epilepsy.
And I'm Teja Mitchell, and I'm an adult neurologist consultant, and I work in East of England. Yes, interested in epilepsy, but I work both in a big hospital in Adam Brooks, as well as in the community and in a smaller hospital. So I get a different perspective of people with epilepsy and young people with epilepsy.
Brilliant. Thank you so much, guys. Cheers. We're going to start off looking a little bit about the lived experience of epilepsy, and we're really privileged to have Sacha with us today. So Sacha, can we just start off and tell us a little bit about yourself and about your journey with epilepsy?
Yes, I was diagnosed at 15 with epilepsy after I collapsed at home, which it was a seizure that wasn't witnessed, so it wasn't seen. And then after that, I started experiencing some absent seizures and some myoclonic jerks. So they did an EEG. And that was when we found out I had epilepsy. And I stayed with the children's department for roughly a year until my consultant actually retired. And then they moved me at the age of 16.
Before that transition, what was your understanding of that transition process, and what did you sort of expect?
I actually they didn't tell me much about it. They just said, my consultant said he was retiring, and therefore they thought it was best for me to move to the adult services. And that was kind of it.
So not much information and
no, it was very much just a move.
Mm-hmm. Okay, brilliant. So yeah, what would you say was the biggest differences? I know you was only in pediatrics for a year, but what were the main differences you noticed when moving?
I found pediatrics was quite, even though I was 15, so I understood quite a lot. They would talk to my parents and exclude me from conversations. So, and they obviously had the consent for medications and treatments. So there wasn't very much conversations about what I wanted. And when I went to adults, that was all shifted. Also, the team, they worked together better with the nurses, the epilepsy specialist nurses who made sure that I knew what was going to happen, and it wasn't so much what I call dysfunctional. Yeah, it was much more, I guess, they prepared me for every stage and kept me in the loop.
Oh, that's great, and that's really nice to hear. And I think having that preparation and understanding about what's coming up for you is really important. So yeah.
Yeah, no, it wasn't much better.
Brilliant. Thank you, Sacha. So how would you say the support and communication changed between pediatric and adult services?
In pediatric, my main person to contact was the consultant, and consultants are quite difficult to get hold of. And so that was very difficult for us because if I had a seizure or we needed to talk to him about something, it took a very long time to get in contact with them. Where in adult, we had a nurse who was very easy to contact and she had most of the answers. She's a specialist. So it was pretty simple.
Brilliant. Yeah. So you really enjoyed sort of that aspect, being at easy contact with a nurse for those questions that sort of pop up in between appointments.
Yeah.
Brilliant. Yeah. So how did you handle your epilepsy care after moving to adult services? Obviously a big change, getting a little bit more independence. And how was that process for you?
Being 16, it was a big change. And I think it's quite young to be in control of every kind of aspect of your medical journey. You're suddenly in control of your medications, your prescriptions, organizing appointments. You kind of have to be on the ball. And so that's very difficult. And at 16, there's quite a lot of other things going on. And you're also dealing with this diagnosis that is very daunting and you're not sure what's going to happen long term. So it is a lot.
Yeah, it really is. And you've touched on there about sort of the other things happening in your life at 16. I think got a question about that later, but do you feel like there were sort of steps involved there, or was it just sort of straight in at the deep end in your transition and you felt like you took?
It felt like it was straight in on the deep end. I have to say that the nurse and the adults didn't treat me like an adult. So that was quite good. Like she made sure that I felt safe, and I think she treated me like a 16-year-old. And then as I got older, obviously, appropriately. But she did some very good things to make me feel safe. Like we had longer appointments so she could build a relationship, and we would have biscuits, which was just a really good bonding while we were talking. Yeah, and I just think it's a really simple thing, but not many people do it.
Yeah. Nice. And yeah, really nice. It's so they sort of adapted the environment for you, really looked at you as a person, as a young person coming into these adult services. And I think that's, a really great approach for someone in your healthcare team to take. So yeah, great to hear you had that quite positive experience and some steps were taken sort of allow you to adjust to this new transition into adult care. Great. So has your independence been affected by the transition journey?
I think having to deal with all your prescriptions, all your medical care independently, and making sure that you turn up to appointments on time at such a young age can have an effect on your independence, because you have to be so independent at such an early age. And it's not something that other people would have to do, because say normally it's 18.
Yeah.
They would start to think about that.
Mm-hmm. And did you, with friends and peers who are not living with epilepsy, did you feel like you was having to lead a different life at that stage?
Yeah, it was very much making sure that I was living a life that was as safe as possible, because we weren't really sure what was going on at that moment, because it was still quite early on.
Thank you, Sacha. So yeah, I think we've touched on about this important time of life. So moving from pediatric to adult care usually happens around sort of 16 to 18. And we know that in every young person's life, they're really crucial years. So can you tell us a little bit about sort of what was happening in your life during that time that you transitioned?
Yes, so I was doing my last year of GCSEs, which I struggled with, and I had to drop a subject which turned out to be science, which later on I had to retake because I wanted to do nursing. So I think it's important that advice is given to people who are doing GCSEs, which are quite crucial, because you can't go on to other things without having certain subjects, especially English, maths and science. So to suggest you drop one of those important subjects was really stupid. And so I think more advice should be given on, if you're struggling in those important years, what to do and what support there is.
So education obviously had a big negative impact on your education.
Yeah.
Leaving you to having to go back and study additional science courses. So yeah, that's a huge impact, and I think this really highlights how crucial this period is and how important it is that transition is done in the best way possible, so it has the minimal impact on other aspects of your life, like education, socializing, and things like that. Thank you. Could you tell us a little bit about a time when you maybe felt either really well supported or unsupported during the transition period?
I felt really supported when I had a consistent appointments with nurses and consultants when I moved to adults. But I felt unsupported just before the move, when I had something called non-epilepsy attack disorder, which is quite common. It's to do with stress. And my consultant said to me and my parents that it wasn't his problem because it wasn't epilepsy related. And that was kind of that. And we had to go get support elsewhere, which was really difficult because he was our only medical link, and we didn't really know where else to go. Luckily my mum was a nurse and had contacts, but it was very challenging, and yeah, he wasn't very helpful.
I'm sorry to hear that. And yeah, having multiple conditions or other things that you have to go to the hospital and work with a healthcare team adds that extra complication, particularly when transitioning. But thanks for sharing that. So this next question is around sort of resources and tools that might have helped you, and I think this is a really important topic. We've spoke about independence and taking those steps, and having good information that's aimed at young people is really important. Could you tell us a little bit about any tools or resources that helped you?
Yes, so my epilepsy nurse gave me lots of resources from Epilepsy Action, Young Epilepsy, and she also gave me some information about SUDEP, sudden unexplained death in epilepsy, which was already helpful because we hadn't been given really much information up until now. We were still kind of trying to understand what epilepsy was, so this information was really helpful.
Brilliant. Yeah, and obviously for your own personal journey, being diagnosed at 15 and then just a year in paediatric for you, so it's really important that you was given those resources.
Yeah.
Was you given any particular resources or tools specifically regarding the transition process?
Not the transition process. It was more about epilepsy, pregnancy, SUDEP, and where I could get support.
And did you mainly access them online? You said it was links.
I accessed them online, but I was given leaflets by the nurse as well, which was really nice.
Yeah, what is your preferred sort of?
I like paper. Yeah.
Okay, brilliant. Thank you, Sacha. Is there anything you'd wish you'd known before transitioning into adult healthcare?
I think just being taught through the process a bit more and explain what was going to happen would have been really helpful, and maybe meet them more, meet the people I was going to spend time with before actually having to rely on them for my health would have been nice.
Yeah, that's a great point to make there. And the final question in this section is, are there any questions that you'd like to ask the experts that are here with us today?
I was diagnosed at 15, I'm now 26, so that's 10 years ago. So maybe what changes do they think have been made since then?
Yeah, I think that's a great question.
Thanks for telling, first of all, of that, by the way. It's made me think of a couple of specific points that I might ask later. Some of them I've thought for the first time, which is really, really refreshing. What's changed since then? I think it's really variable. I feel like the best. You mean in terms of the process?
Yeah.
Sacha. I think so. Say for the way I practice in the service, two services I work in. We look to prepare somebody, a bit like sort of Cam was hinting at, that they're going to reach this point where they'll be transitioning over to adult services. We try and make it quite gradual. And I suppose the difficulty in that for you was that it was 15. That you had this year where if you stick to 16 as the point where you're going to transition, it's not much time to do that preparatory work, because you've got the initial stuff to deal with, to come to terms with, for that to be explained to you. So it all gets very compressed. So what I would tend to do is not be rigid about that 16, because I don't feel like you would have been under my service and we wouldn't have been providing care for very long. You wouldn't develop the relationships that we'd like you to develop with us. So I wouldn't have looked to transition somebody in your situation for a couple of years, I would have thought, actually. Sometimes the other thing that we get is if somebody's literally at their 16th birthday, we might have a discussion with our adult colleagues. Actually, is that somebody that you're able just to see first off? So you don't need to have that interface, and that you get a bit more consistency. But I think in your case, I would have probably, it's not a change per se, it's probably just how I would have practiced. I probably wouldn't have ideally done it the way that it happened with you, but then I'm not that close to retirement, so maybe there was another factor in play in your case. So what do you think?
Yeah, so what I would say, so I started my experience and interest in transition 20 years ago when I went to Sydney for a year to do an epilepsy fellowship. And part of that, I did actually a transition project to start a transition program for people with epilepsy from the 2 children's hospital in Sydney to the 2 adults. So it gave me an insight really about the barriers, the challenges, and actually the different perceptions that paediatricians have and adult neurologists have about how that should work. And I think, to be positive about the last 10 years, in that time, we talked more about it. I think we've got more people recognizing how important it is and trying to meet up together. Because for me, even now, I would struggle necessarily to see every young person that needs moving to adult services from my paediatricians. Because I think one of the things that I highlight is that in the adult service, we're seeing from 16, 17, 18 on to 90s. So we have and there's nobody for us to pass on to. It's us. So that poses challenges in trying to pick everybody up. But I think we're getting better at having those conversations. So I've got personal experiences of my oldest child going through transition for a different reason. And I think what I've reflected on that has helped inform me and what we drive to change is actually, if you work together, we can help our paediatric colleagues kind of inform the young person of where they're going, and that's a joint plan. So even if you don't see the person before, you know that your current clinician is working with that team. So you have it was difficult for you. As I said, it's made me reflect on your experience and going, wow, that was tough, because I think it's not just getting used to diagnosis. You weren't stable at that stage. Yeah. So you don't actually know where you're going. And suddenly, even if I suspect he'd said, I'm retiring, but one of my other paediatricians is taking on because you would have needed somebody, that might not have felt as big a jump. So I think that's, particularly to you, been very difficult. But I think perhaps having that, I work with the team. Yes, they're in a different service, but actually you're going to get older and you've got different aspirations that they might be, more familiar with, plan better with you than I can as a paediatrician, and knowing that working as a team together and knowing what information we would like them to start talking to you about, them knowing more from us and having more flexibility around that transfer. And I think that is shifting. It's not done. It's nowhere. And so, the other side of me goes, oh my goodness, I've been doing this for 20 years and why am I still frustrated? And I think the other change that I'm trying to convey is transition and transfer are 2 different things. because people put it together. And I think we still have lots of services where it's very focused on actually transfer, not the preparation. Like you say, now knowing, I encourage a lot of my young adults to talk about going on the NHS app to order prescriptions so they can do it at 2 a.m. if they want to. And they're not having to get through a phone line to a surgery that's always full in the middle of the day when you might not be up or you've got other priorities. So it's, and those sorts of things can start happening early, and it's conveying that information and getting people prepared. So I think that change is coming, but it's so patchy. And I think it's still down to people who are interested, isn't it? Or motivated, or see that as one of the things they really want to do. It's not as universal as we'd like it to be. And I think that's the remaining challenge of how do we get teams around together who are struggling with the constraints of their own bit to do that overlap better. But I think giving that impression that we're a team, and though you're moving almost from one member to another, and why that is and what can help you, rather than you're leaving something behind and you're going somewhere into the dark, unknown to the other side of the galaxy, which sometimes can be the impression. So I'm pleased to hear you had a bad experience in adults, because commonly it's not the story we get.
Well, I don't know about the stories you get. It's because, as was pointed out to me in a talk we had from an adult neurologist a couple of years ago in our sort of clinical network in our region, it was what happens a few years later. It's still not complete sometimes. So we think we've done the bit we're supposed to do, and we've prepared a young person really nicely, and that's how our system works. And so we assume that's optimal. But obviously how somebody does and what new issues come up for them as an individual makes that variable. So it might be 3 years later that they're kind of settled. Their epilepsy might be stable, but in terms of their care, it might be settled a few years later. So but what we tend to think of in pediatrics and what gets talked about as a term is like the cliff edge.
Yeah.
So we're a really lovely set of people, usually as a team. Usually you will have not just the consultant, but a team, right? And you're the standard, if you like, what we aim to do in most services, I think, across the country is have that contact for the service that is responsive for a young person in the family. It may be the consultant, but more often it is an epilepsy specialist nurse. We know they do really good work, and there's really good evidence around how effective they are. So we feel like, and it's all very hospital led. That's the other thing. So that was a change 20 plus years ago that was thought to be improved, would improve care. And I think it has been borne out that has improved care, but that can be overly protective, because then you make this transition into an adult service. Depends where you are. They don't always have the equivalent. So we often talk about cliff edge. So to my mind, that's our fear as the pediatric service, is that we're not setting it up to fail. I don't want to say that, but we want to make sure that it's mirrored on the other side. You had the opposite, which is really interesting for me, and I'm definitely going to reflect on that. But it's not a perspective we hear very often. Maybe we don't seek out the perspective very often to hear that. But
open to a lot of young other people, and they had a complete opposite.
The other thing that you said that actually before you made this point was about your independence, and I thought that's something I'm going to take back and think about for my practice and for the region, because I'm sort of head the stuff that happens in my region as well. Is we often think about epilepsy constraining a young person's independence, and that's the battle. It's like we want to keep you well, and thinking about the goals of what you want to be doing in your day-to-day life, actually to maintain and hopefully optimize your independence. You seem to say, if I get it right, that you felt like your independence accelerated compared to your peers. You suddenly had to be much more independent than they were, maybe before you otherwise would have been.
Yeah, I think to be well, I had to take more independence and to grow up a bit more so that I could be weller, because not everyone my age was kind of thinking about drinking, and I had discussions about whether I should drink, whether I should be doing things, whether I should be going out with people that may not be sensible enough when I had a seizure. And I think that they're just conversations that at that age you just have to be quite grown up. So it kind of just affects that independence.
So I would add, I mean, one of the other things that when I talk to my pediatric colleagues about transition is going, because they have this perception of perhaps adults not appreciating that link as much. And I actually point out that in the adult service, I take people with epilepsy through many transitions in their lives. So I've got, if they've come in under 18, I take them through the transition from being in a very structured school setting, because the number of young people going to work at 16 has dramatically dropped in the last 25 years. So they're in education for longer, and that's a change. And then we do another transition sometimes for people who go into university or another structured kind of work or educational setting, so transitioning them into the workplace. And then we have other lifestyles, both for men and women, about parenting, and then kind of the challenges of middle age. And then we have a huge number of people that get their epilepsy first when they're in older age. And that has a real impact on how they live their lives, their independence, their frailty. And so actually, we have lots of transitions. And that's why I think sometimes when I talk to pediatricians that I'm thinking at 16, what are the conversations I might need to have at 25, 30, 50, and which are the ones that I need to think about now to not be in a difficult position or not place that person in a more awkward position on making those choices. And I think that bit comes into that independence as well, where I think for some services it's very much you're the young person, now we talk to you, and there's a big jump up. I think something we could do better is perhaps soften that a little bit of how people can help. So for a start, so the app at 16, a young person can have the app themselves, but actually you can get consent for your parent to have a link into the app. And I sometimes will say to the parent, well, to create independence, if that young person is able to order their prescriptions, let them do it, but you can check it's done. Mm-hmm. So that's kind of, they're not falling, you're not running out of meds, because clearly we don't want to do that. And I think in pediatrics, there is a lot more about how do you support parents to support their child or young person being safe, versus in adults, it's how are you safe to live your life and what do you think about? So I often talk about friendships and talk about, are there some key friends that you could have that conversation about? And I often reflect back saying, because I wonder if one of your friends had epilepsy, you might want them to be safe and be mindful, and that you might want to alter quite what a night out is because you want their company rather than excluding them because they don't feel safe. Not because of you, but just the environment. And so we will often talk about that to go, yes, it's an adjustment. There's no way around that. There are restrictions. But actually, it is a time in your life where you are finding out yourself and where you are in society and where you are with your peers. And we don't want you to lose out on that. So how do you navigate that? And I recently went to an event about transition where the young person talked about, they'd always been told they can't have a shower alone. And we would never say that in adults. We would actually say, how do you safely have a shower? And it made me reflect to say to my pediatricians, actually when that sort of young child actually goes from needing an adult to bathe them and you move them to shower, move them earlier so that showering is all that they've known. I mean, that doesn't apply to you at 15, but we've got people where they've had epilepsy younger, they go through that shift and they're at an age where they can be supervised, but supervise them in something that's already safe, so then it's not something you're taking away in adolescence. And I'd never thought of that because it doesn't occur to us as adults that supervision is there.
It's conversations like today that help us think about it a bit better, I think. Going back to your question about what's changed, it's probably longer than 10 years as a aspiration, but you see it much more in practice now, and there's a bit more of a framework from the NHS that this is what you should be doing, but having young people's clinics. So you have longer clinic slots, the practice of speaking with a young person first and then their parents, as in bring the young person through into the clinic room first and then their parents, is the ideal. So having those longer slots so that you can precisely talk about these sorts of issues, almost be led by your agenda as a young person, and that's what you cover first, because actually that's probably what you're thinking about in a waiting room. You go in, and if you're just suddenly bombarded by all of our normal questions, what we're thinking of, our agenda, then you're probably not going to be very satisfied, and then not very prepared, even if we have got you on this process, this long process. If we haven't done it in the right way, and what people call developmentally appropriate, I suppose, that's the whole drive for us to be thinking in that way. We need to set it up that way. And the young people's clinics, like I say, longer slots, very much I would go in the mindset that I need to be considering these sorts of issues and open to discussing these sorts of issues. Having that system where we would speak to you first and then bring the parents in when you're comfortable, hopefully starts to prepare it, but it means that we cover all of the right things that are important to you. Like I said, the slight disclaimer on that is, and the difference is, you're 15 at the point of diagnosis. I suppose you would have gone straight into that sort of system as soon as you were stable. But again, you need the time with a young person, like I said, over at least a couple of years, I think, to get to that situation. It sounds like you didn't quite have that. The challenge is sometimes, of course, that we've looked after people since they were, preschool or an infant, and then you have got parents who are very much ingrained into this is the way it's been, and you do naturally carry on speaking with the parents that you've always had a relationship with. You do not forget, but you maybe need to stop and consider that they're not 2 anymore. they're 8 or 9 now, and actually, we should be saying, "What do you have any questions for me?" And then they're a little bit older, and actually, it should be then this model of a young person's clinic where you ask us questions first. And I think sometimes we need to be reminded, and sometimes setting up the structure of our practice is the way to do that.
Because I would add to that I think transition and transfer for parents and carers can be really difficult, because actually, particularly parents that have really had to be mindful about risk and managing, and then we suddenly say, well, we're going to talk to the young person. They go, no, but I've always been involved, and they feel excluded. And so I think that's the other trend we're trying to tackle on the adult side, of being softer on that, saying it's not excluding you, but actually there is a focus that's different. And I think, again, working together so that becomes a more gentler introduction, I think is something that is changing, but still needs to change further on that side. Because I think that's sometimes from the parent and carer perspective, their difficulties and difficult experiences have always been, we know our child, we've brought this up, and we're not being heard anymore. And you're trying to balance that other side of going, how do you hear? But actually the priorities do change, and that young person needs to be given a voice, even though we've got quite a few families where the parents and the young person have the same priorities. Parents are very connected, do want that person to be more independent, but without the risks. And sometimes I have to have direct conversations with parents to go, there is no zero risk situation. How do we navigate it? And I say to the young person, if you could show certain things to your parent to say you're taking responsibility, I can then say to your parent, you need to let go. And have that more direct conversation. Not say not be involved, because I still get support from my family, my parents. That's what family's about. But it's how do you navigate it? It's to say the reason you're holding on, I recognize that, is for safety. And it's risk. And I think, and if you've watched your child or young person have seizures, particularly tonic-clonic seizures, you never quite overcome that anxiety and fear of that situation. And so, being actually very open that I recognize that fear, but how do we move on? Because actually we want your son, your daughter to be more in control. And actually from an adult perspective, particularly those that don't get seizure free, my aim in my practice is, how do I help that young person to still aspire and have the confidence to go and do the things they want to do, even if there needs to be some adjustments, living with their epilepsy, because I know that I can't take it away. So I have to find an alternative for that. And I think that's also what drives me, my desires of working with sort of transition programs and national guidance, is going, my perspective is, how do we give that confidence, that aspiration? And those first 10, 15 years is critical to setting the path for young people for their kind of adult life. That's where the opportunities come. And that's where the loss of opportunities really, even if you get seizure freedom later, very difficult to get it back for that person. So that's the window we have. But I guess that's it. That's the other, we're thinking 10, 15 years ahead, not 2 years ahead.
Something that really stood out for me there is about like the person-centered approach. I think it's time and time again hearing you like really looking at the individual. What is it about their life and their family's lives? What's coming up for them? And that was just really sort of inspiring, heartwarming to hear. And I think that's the best approach, and what hopefully more and more young people can experience. So thank you. Great question, Sacha. Thanks for that. Cool. So I'm going to move on to what to expect when transitioning. I think we're really lucky today to have representation from adult and pediatric services. Obviously crucial to have everyone working together to make sure this process is right.
So I think it does depend, like we said earlier, about at what point you come under a pediatric service, a children's service. So when somebody is looking to, has had a suspected seizure or they're unsure about what an event was, there's that whole process of diagnosis and seeing somebody, getting your assessment. And somebody's pointed out to me, it's not like it might be for another long-term condition where you could have one clinic appointment and walk out knowing it's yes or no. It's a process. So there's not necessarily one investigation that will tell you. It's putting the piece of the jigsaw together. And that can happen at, as I said earlier, you could have babies, infants, preschool children, primary school age children. And so all people of different ages have come in to a pediatric service at that point, and could be with us for years. Or you could come in at 15, like you did, Sacha, and then you're not really under pediatric service for very long. So what we try and do when we know somebody's going to carry on being under an epilepsy service and hence need to be under an adult service is prepare a young person. And that is best practice. And that is now laid out in like I said, it's a framework in something called the bundle of care. And there's nice standards around that as well, nice guidelines, in fact, about how we need to be doing these things. And so the aim is ideally you have a young person's clinic, a specific carved out bit of time that's more appropriate to have the conversations you need to have with a young person and touch on topics that you wouldn't have needed to when a patient was younger. And so starting at sort of the age of 13 is kind of widely seen as a suitable age. But again, within that, you've got lots of flexibility and you'd be ideally led by the young person. So what that looks like is a series of appointments where you're not then just touching on the things that maybe you used to do, where you change the focus of it so that you're young person led rather than parent led. Still have the parent perspective and the parent voice in there, and they're not always the same, which is quite interesting. So I still remember this from years ago when I was at a presentation of some data. They had a young person speaking. They asked him what his biggest issue was, and he said, "My mum." And it was because his mum he was 13 or 14, I think, at that stage, and he'd had epilepsy for a few years, and he was being quite constrained in terms of the independence he wanted to have. Right, he's a teenager, he's an adolescent. Taking risks, widening horizons, all those sorts of things. He really wanted to do that, and he wasn't being allowed to because his could be a mum or dad, right? As his parent was terrified. The epilepsy had started at an age where none of that was a consideration, and now he was at the age where that is the normal sort of thing that needs to be done, and probably wasn't ready to move in her mindset, but he was. Right. So the point is we need to take that sort of stuff into account. And you're right. How can you, I often say this to young people, to motivate them actually to take the medication, to get the best control, is what are the things that kind of motivate you? What are the things you'd like to be doing? Where do you see yourself in a few years' time? You know, is it that you're going to a certain career? Is it that you're going to be going into higher education, whatever it is? And that's the kind of hook. I want to know it, but it actually helps to be very young person led, to direct your care that way. And also I think that is what helps bring parents on board, because they can see that's the overall lane. And that is what helps towards going under an adult service, right? Because that's how it's going to run there. But it's this gradual process of changing our focus, I think, and being much more young person focused than parent focused, without dropping one or the other. Okay, so it's a series of there are various structured frameworks and tools that you can use for that. So there's a thing called Ready Steady Go Hello, that was developed in Southampton for a different condition, but we use for our patients with epilepsy too. That works well, we think, but it provides a structure, and the point is it's not a you have to do it exactly this way. It's a framework that you can then use and individualize as you need to.
So what can a young person expect during the transition process in paediatric care?
Yeah, so it's it might be done variably, but if I talk about what the kind of aspiration is, there are certain principles I think along the way of how it would be. So we would aim to start this as a gradual process from around the age of 13. That tends to be a bit of a consensus around that. Now, this can be in a standalone or a separate clinic. So although you would have been seen as a child if you've been diagnosed before that, in a normal epilepsy clinic, the same person, so a pediatrician with an interest in epilepsy or a pediatric neurologist, whichever person you need to be under, will sometimes have a separate clinic that runs on a different day of the week or whatever, but they have a bit longer. So they call them a young person's clinic. And then the idea from our side is that we go in with the mindset of talking about some of the issues that we were covering earlier, and being appropriate for that young person, whatever the kind of emerging issues are for them as an adolescent, a teenager, are brought into that, and investigate that, interrogate it a bit, obviously advise and manage that as appropriate, and then start to signpost to how things may be going to be later on in that process. So we start with 13, obviously we aim to 16, 17, maybe 18, transfer the care over, but that transition, that process starts at 30 ideally. Now, not everybody, reality on the ground, will manage to have a young person's clinic with, say, 30-minute slots or longer. So the other key principle of that is this seeing the young person first, ideally, and it is what we try and do, and then have a parent come in afterwards, and the young person starts to take that primary responsibility in the driving seat, if you like, for managing their epilepsy. So those are the principles. So what we try and do, there are various things that you can get in terms of like a framework or a tool to support that. So there's something called Ready, Steady, Go. There are other transition frameworks out there. So that's what teams and services try and follow, broadly speaking. Obviously, it depends on the age that you're diagnosed as a child or a young person. So if you're diagnosed at the age of 15, then it's very difficult to go through it in a slow and steady way. But I think it is still, I think there's still merit in doing, replicating that as much as possible. So as long as somebody's stable with their epilepsy and kind of ready to start that process and approaching the age where they would transfer over to an adult neurologist, then I think, again, going back to your case, Sacha, I probably would have tried to start some of that. And you would have already, I suppose, thinking about a 15-year-old coming into a service, need to come to terms with their epilepsy. They need to be medically managed. But you wouldn't wait, actually. I think you'd start to try and find out what is it that motivates them, what are the things that are going on in their life, what are the kind of normal teenage adolescent issues that are important for them now and are on the horizon. So you kind of automatically get into it, hopefully. The difficulty, I would say, is the reason why we have this kind of 13 in mind and the idea of young persons come along, is that you often, as a clinician, have this longer term relationship with a family and with a child, and then you kind of forget, oh, they're at the age now, this is happening for them. So you do need a bit of a prompt, you do need this kind of structure to follow. Otherwise, before you know it, they're 14, and you're, oh, no, I haven't really touched on any of the things. They're doing what now? I remember when you were 7. So it's, yeah, that's the broad principles of what we try and follow. And then again, it depends where you are. And you said this earlier about transition and transfer of care being very different. But having a joint appointment or appointments with your adult colleagues, I think is really useful. Not just that, but you will need to have that at some point. So you try and do this lead up. You have your joint appointment or appointments. different members of the team sharing information about that young person so that nothing's lost, hopefully. And then it's kind of over to you.
And I don't really know what happens after that, if I'm honest with you.
Well, so I would say from the adult perspective, what I think we should be aspiring to is, so I think is firstly that we have worked together on that process. And also that allows people ideally to embed some information in that young person's clinic about what it's going to look like. Because you start talking about it. Because I think it's also difficult, even if you are able to do joint appointments, there's a bit of nervousness. The young person, the family sometimes going, oh my gosh, I'm leaving. So even though you're doing it as an introductory, some people can view it as this is a letting go. So I think embedding what does it look like a bit earlier, I think is helpful. I also think that, and this is what we put as part of the sort of bundle of care, is that early on, this sort of have a loose it is an individual transition plan should include where that transfer is going to be to. Because actually, particularly with epilepsy, we've got the epilepsy can vary. The complexity of the epilepsy can vary depending on what sort of drugs people are on or whether they're going through surgery or have had surgery. But we've also got different sort of developmental stages that people can be at or can go through. We've got obviously the co-occurrence with autism, with learning disability. So you've got to adapt to that as well. So there's a range of things that you've got to think about. And therefore, I think it's important that as part of that process, ideally, the person who's starting that transition conversation with you knows where you're going to go to, who that's going to be with. And not just because they've thought of it, but actually those two teams have had that conversation together. And something that we've not yet done, but are trying to aspire to, and we've just started, is having, so where it works, actually in Peterborough where I work, is what we've started to do is doing a joint clinic for the people that we've identified we need to see together, because there's some various issues that would be helpful. But then at the end of clinic, we run through people that are coming up in the next 6 months, a year to go, where would that be? Is this an appropriate time? Isn't it? And actually, we've had the joint conversation so that my pediatric colleague also knows perhaps what the limitations might be for me to influence when that transfer could be, who it should be to. And I think that's what that bundle of care is, starting early, giving a vision so that's not a cliff edge, going, actually, do you know, we have planned this. We're going to look at what you need, but actually, partly, I think the young person, the family are going to you for your experience as to what would be best next as well, that we've thought that through. So that transfer destination, that there's been a collaborative decision of what transfer destinations may be appropriate for certain types of young people with the certain types of needs, however complex it is or not. That because that then allows you to try and make sure those services are ready themselves of what to do. So I think that's important as well. And I think, again, epilepsy can, for pediatrics, be not its only condition by itself. It can be a symptom of other genetic conditions, other things where the person may have other needs. And we've got to have that conversation of what is transition and transfer going to be like. And it may not be that the pediatrician does all of that, but at least aware, say, mental health services, therapy services, what can look like. And I think also, again, from the adult side, I would say my reflection is that though people are not pleased with some of the gaps in service, that people find it easier to adapt to knowing ahead what may or may not be available than suddenly find out when they need it, something's going to stop and not continue. And having that honest conversation of what we can achieve and what we can't achieve. So I think aspirationally that young person clinic is great. I don't think that's always feasible, but actually starting that conversation of you are going to need to be on medicines long term. Or for some people, even starting that conversation of do we try stopping meds, but what does that look like? And if that doesn't work, we then may be thinking about transfer. What does that look like? Because I think the other side we get is people who've come off medicines but have a seizure recurrence between 16 and 18, have left pediatrics on the impression, this is it. I don't need to deal with this. And then that disappointment that comes through from a clinician they've never met before. And so I wasn't the one who stopped it. So some of those questions that make transition then very difficult and transfer difficult is also the disappointment of a promise that people know that it's not 100%, but they're dealing with that disappointment. So I think those sorts of ideal preparations are good. I think the transfer, ideally be good to have that joint clinic. But if there isn't, that there is a joint conversation with professionals as to who, it may be that some people actually are doing really well, are seizure-free, are coping really well, have been prepared well, may not need a consultant appointment, but actually could have their epilepsy nurse as their point of contact going through. So, but that isn't suitable for all services. So that helps you adapt what you have and therefore also know what you don't have and how you mitigate that. And then I think post-transfer, it's thinking about, again, who are the people that need shared care with the epilepsy nurse? How often are they going to need a consultant appointment? I think one of the things, again, to embed a bit earlier, but my first conversations, I talk about what happens if you come to A&E with a seizure, because that's very different in pediatric and adults. There is no, most hospitals have a pediatric ward, unless you're in a children's hospital. In almost every hospital, there is more than one adult ward. You're not going to be on the same ward and get to know the same nurses. You might have different doctors. Not all hospitals will have neurologists there with inpatients. So in Peterborough, I don't look after patients myself on the ward. I provide an advice service because we don't have big enough teams to manage that. And people need to know how it's going to be different and prepare for that and what you need to mitigate. So on the adult side, it's then talking about what does the service look like? What can it offer? Where do you go for help? When there's a crisis, what does that look like? Because again, finding out in a crisis what it looks like is the worst time. There is so much stress and illness and worry. But actually, if you know that's where it's going to be, that prepares you. We talk a lot about the hospital passport, and not just for people with autism and learning disability, is actually going, what is, for that young person, what could that admission look like? Because that accounts for some people who at 16 or 17 are actually quite, developmentally mature in their independence, and some who are not. So some may still need their parent with them. How do we navigate that on an adult side? So that helps you tailor. So I think that's still, then you've done transfer, but if we think about transition, not so much between services, but about developing the skills to navigate living with your epilepsy and navigating health and social care services, then you're talking about a much longer process. Talk about universities. I mean, again, we talked about epilepsy nurses being the glue in all of this. I know my epilepsy nurses are very familiar and experienced of advising people if they're going to live in halls. What are the safety things they need to think about? What is the information? How, it's different now. That has changed in the last 10, 15 years where you don't have bathrooms anymore and you have showers and things like that. But some university will say we want the person on the ground floor so we don't have to navigate narrow staircases. If they need, an ambulance or something, there's easier access, or certain halls where somebody's on duty. So all of those things then become about that independence and living with their condition, even if they're well controlled. We talk a lot about apps and how to reassure your parents without you feeling they're spying on you. I mean, that's a bigger conversation anyway, but particularly for people with epilepsy, how does that work? So I think that's where on the adult side, particularly, it is very much about where your aspirations, what do you have to do? Driving. What are the driving regulations? Kind of being aspirational, but yet kind of truthful about the likelihood that somebody's going to be able to learn to drive. One, based on their epilepsy. Two, based on their cognitive processing, because we know that can be affected either because of different conditions or drugs or other things. Sexual health and fertility. Something that I think has changed, but still needs to change, that pediatricians are taking on that topic. They're very squeamish. They don't think of the young person growing up when we kind of go, actually, if you look at national data, it's already happened. If you think it's going to happen when they're 25, forget it. That information isn't actually about going into adult services. It's relevant to the person there and then for a lot of them. Okay.
This is where the frameworks are the tools help, I think.
Yeah. So
they're not religiously sticking to them, but they are reminders and prompts of you're right, conversations that we might otherwise find difficult.
no, and that
Because we're not having them. Well, it's multifactorial, isn't it? We don't have them very often. We know them since they're a child. Got parents in the room because that's how it tends to run when they're younger.
yeah.
So this is where it's important to think. Actually, we should be doing this a little bit differently.
And I think it's, again, as you say, we have these conversations. You know, I will be having conversations about sexual health, contraception, fertility, family plans for people from 16 up to their 40s. So I do that very often. So it's quite natural in that situation. And I think the frameworks and the bundle of care, because I was involved in writing some of those recommendations, we've got a table in there that sort of talks about what are the key essential components and what are the aspirational. Because again, if you set a goal standard that's so high, people are put off starting because they think they're never going to achieve it. And that was the thinking behind that. But actually, the table looks very long and it was a working party. So obviously it was a consensus that was drawing up. But actually those key themes, there's a lot about epilepsy information, but actually there is navigating health services. That's another bit about the app, about GP, about getting consent for your parents to still be involved. Sometimes, you know, with the young person's consent, because they can do that independently with support, to those that clearly cannot and will always need advocacy, that's brought in the hospital passport, some of the legal aspects. So it's kind of setting that framework of going, think about it. Because one of the things with my pediatricians, I've said, you know, once somebody turns 16, from the legal perspective, to put it in place, so much harder versus actually it was predictable that was going to be needed. And what information can we convey so parents aren't in that position at 18, 19 going, I'm now told I don't have a say. But actually clearly they still need to. So I think that's our aspiration, isn't it? Is to have the structures in place, but people knowledgeable, people thinking very much about that young person and focusing on their aspirations, and planning and having those conversations, and actually also being realistic as to what's deliverable and how you can mitigate. You know, because we talk about best practice, but we also have to recognize best practice has to happen in the real world, where we're never going to have indefinite resources. So how do you make more of what you have go further? And I think collaborative working is how you make it go further. That you can embed information across both sides and you make a plan together, because then your influence goes further without you necessarily being able to see everybody all in the same way.
It's just great to hear about that collaboration. I think from the patient's perspective, really just comforting knowing that these sort of two separate, are they really separate, who knows, but two services really working together to provide the best care. Something I'd just like to ask you is, if any of our listeners are listening in and not really understanding their own personal transition process, maybe at their age of like 14, 15, it's come up, is there any advice you could give to either a young person or their families into how to get more information about their own personal transition?
But I would say their starting point should be their team, and ideally that's their epilepsy specialist nurse. And you can, again, should be open to questions and questioning, and should be able to reassure what, a bit like we've just been covering, how it's done there. You know, in that service might be a little bit different than what we described. We've described a lot of principles, but exactly how it looks might be slightly different. So it might be happening when they don't know it, or it might not have started it because they're starting at 13 years isn't quite what they're managing to do there. That might be okay. They might have decided between the services. That's fine. And I think then there's the resources that, like Young Epilepsy, so provide things like the channel and the other support that's out there. I think is really good for signposting, because what we do on the pediatric side is a gradual process. So it might, like I said, it might have started, should be pretty explicit and clear and not at all opaque, but sometimes, somebody's on that and hasn't quite realised. Or, as I was saying earlier, try and be developmentally appropriate for that individual young person. So they might be ready for the next bit, and actually their team hasn't realised it. So all that's needed is a prompt to their team. So we haven't really covered this yet. And then the team know, okay, we need to cover that now, because we didn't think that was quite on the cards yet. But something's happening in that person's life that means, we're at the stage of, you want to have a driving discussion. Great. We haven't had it yet because we didn't think it was, but you're thinking, okay, in 2 years I might stop and I'm 50. So this is actually it's the most important thing to me now. So I think giving the agency to a young person is what we hope is there, but being a contactable service is probably hopefully what drives that. That's like the practical way.
Brilliant. Yeah, I think great advice to approach your healthcare team and ask direct questions.
So I mean, my advice, I'd probably, again, from somebody who's not having to start it off, but afterwards, I'd probably, because I think there's some areas where it's not as transparent, or perhaps the resource isn't yet there. I would be saying to somebody, actually, the first question I'd almost say to my team is, am I going to have epilepsy and be on epilepsy meds when I'm 16, when I'm 18, when I'm an adult? Because almost that's thinking ahead, going, and those conversations are likely to have been heard before, perhaps with the parent, because often we get then adults, am I going to have this forever? How long am I going to be in medicines? But that conversation may have been some time ago. So my first thing is, if they're thinking, am I going to need to, is actually say to team, am I going to need to be on this long term or into adulthood? And then the second question, if there's a yes, is, so, I know I'm going to grow up. How are you going to help me? Or what is there to help me? Do I stay with you? I mean, I think it's because some people, what I was really aware from my experience in Sydney, where the healthcare is structured differently. I mean, we had paediatricians who had people in their 30s still that they hadn't let go, but that's partly to do with what's covered under a national health framework, Medicare, and privately. And almost to introduce that, so I think some people might feel a bit that they can't be critical of the team. Why haven't you done that? So say, am I going to need to be on it? Do I stay with, will you be taking me through? Am I with you? And then that opens up going, no, actually at this age. And then you might need to move to adult services and then go, well, how does that happen? Who do I go to? Because that then helps those conversations. What do I need? And I think some people we've had, might even think, well, is it for us to sort out? Do I have to go back to the GP to get that? And go, do you talk to that team? And I think those are the sorts of prompts to go. And this is partly influenced by my experience of my son going through transition, where actually, I have to say, it was probably slightly unfair on the person receiving questions for me, because I'm obviously much more informed about transition, having worked on the framework, knowing what should be there and what the actual nice guidance is about transition as a whole, not just for epilepsy. And I realised that actually there was no conversation between the teams, and me saying, well, surely
have you read
you need to go to well, yeah. I won't go down quite how that conversation went, but I think for the young person, the family, going, well, how do I move on? Do you talk to them? Because then I think that gives you that reassurance, isn't it, of, well, actually we haven't started, we might start that in a few years, we don't need to yet, you're going through medicines yet, we're not sure, or okay, we'll talk a bit about that now so that you know what's happening, even if you don't start the detail, but actually we'll go into the real detail in a couple of years' time or in 18 months. And I think that's a good way in if you're really worried, knowing that it's going to happen and you've no idea how it's going to happen, is kind of be as specific as that.
There's no such thing as a silly question, essentially.
Yeah.
That's what the message is, hopefully gets across to people. Because when people, I always ask at the beginning, I always ask at the end of the consultation about people having questions, and whatever they say, I often reply, that's a good question. And then I go into it, and it might be, put a pin in that, and we'll come back to that in 2 years. But that's the point. But at least I know that's important to you.
And you make them.
But usually it's just really relevant right now. And I'm glad that they asked it.
I mean, personally, I love people who come in with lists of questions. I know that doesn't always sit well across, but I like that people have thought about it. And then sometimes I will say, we'll come back to that. And at the end of the consultation, I always say, do you want to look at your list, and is there anything burning now that we've not covered that we need to do for now that I can answer? And part of that strategy is because I know that my appointments are quite spread out. So I've got to keep people going for longer, even with the nurses in between. So, and I know when I seek healthcare services, even if I go to my GP, I have my post-it note with the 2 things I'm going to ask, because I'll forget, because I'm stressed about not wasting their time. And I know their time is precious. So having reflected that I feel that pressure, I say to people, it's okay, they're just prompts. And if it's not appropriate to talk about it, be open that they may say, that's for later, or that's not relevant. But it's much better to put them down. So I often tell people, especially now with phones, just keep adding questions. And then just before your appointment, look through and see if there's repetitions, what's more important then. Because it actually, for me, I find it helps frame the consultation. And actually, we should be encouraging that. That's where people take ownership and self-management. And as medical professions, that's what we should be encouraging, because it helps us.
Prepare yourself. If your patients are listening in, they're going to be coming in with a list of 100 questions.
What I have had, I've had 4 or 5 pages of symptoms sometimes and things. The other thing is because it helps me read the symptoms in people's own words rather than what they think I need to hear sometimes. And sometimes I've said, actually, this is too much for this consultation. Let's have that consultation. And if afterwards I read and I realize we've missed something, I will add that to my letter and I'll highlight it. Okay. Or I will make a point of going, I omitted to talk about this. We'll talk about it next time. As a way. Sometimes it's not easy to look through all of it together. And I always put those into the records. I always say, can I have a copy? It's really useful reference because you get to see how people are thinking.
Brilliant. That's great advice. Yeah, it's great. So yeah, big takeaway there is just, speak to your healthcare team, because every transition is going to be different. To get that real unique understanding of what it's going to look like for you, go and speak to your healthcare team. But also signpost, great for the shout out for Young Epilepsy, Emma, thank you, for a bit more generic information. I've got a little question here just about what kind of healthcare support is available when you move away. For example, like if you move to university, how can a young person sort of manage that move?
I think that's more for you.
Have that.
So I think that's where epilepsy nurses, either pediatric but most likely adults, are really crucial, because they have built a bank of knowledge about the sort of challenges that people may face, also sometimes opportunities. So I think there is thinking about some of the apps and the digital ways of supporting safety and seizure recording and getting help. There is very much about what help can be available in universities, appropriate accommodation, looking at safety, any support networks that are there. I think the other aspect is really having that conversation about the social aspects and how they're going to navigate, feeling they're excluded, but how not, how to mitigate that and how to help support those conversations. And I think sometimes young people just want somebody to sound off that's experienced, to go, that's okay, or think about it that way. Because of course we hear from lots of young people, so we absorb people's experiences to then be able to go, somebody mentioned this and that was really helpful. You find out. So that's partly what I think a young person is getting from us, is our experience of other people who've gone through it before, and go through. And then I think the really other important thing that I always talk to our young people and our nurses do is that depending on their type of epilepsy, where they are, what control they have, what meds, is do they stay with the home team? Because actually things are very stable. So if there is a call out, it's not predictable. They're going to need help. But then if they do need help, it's much better it's a team that's known them, even if it's only for a few years, and keep that responsibility. Or do we need to transfer them to a local team because things are more brittle? They might be going into A&E where then it's very difficult to manage from afar, and we need the local epilepsy team to be supporting them. So I think that's the other aspect, is going, actually, what does your healthcare look like? You know, are you going to get your medicines from your home GP, or are you going to transfer to your university GP practice? But then how are you going to get the medicines during the summer holidays? And how do you navigate that? And really finding out for the individual what's going to be best. I mean, there has been quite a lot of work, because this has been highlighted to the Royal College of Physicians had a young adolescent steering group talking about transition, about being temporary residents, either at your home address or your GP address, so that you cover those periods and things. But people need to know that is a thing, that they can have that care. So we talk quite a bit about that aspect as well, of going away, what that means, what your healthcare is, and what's your epilepsy like, to know what model is best. So for those that are well controlled, I tend to try and see them during the summer holidays. It gives me a bit of flexibility, a bit longer to get those appointments in. And our epilepsy nurses actually, even though that person might register with a local GP in a seemingly out of area, we've made an agreement that we will keep them under our service. Those who are complex, I sometimes share. I will say, you know, I'll just see you in the summer holidays and I'll let somebody else do all the active treatment. But if at the moment the plan is you're coming home, or you will, in 3 years' time, you're not necessarily going to have settled there, then I'll just keep in touch with you, because I will need to pick that up, and gives me a bit of continuity, and you can update me on what's happened. So you kind of flex that model.
Yeah, no, that's exactly. It's great to hear that flexibility that's available. Yeah, really insightful. Thank you. So could you tell us, we've spoken a little bit about sort of the aspirations of what sort of a perfect transition looks like. Would you be able to sort of tell us a little bit more information about what it looks like on the ground in real life at this current moment in time for a transition?
So from a pediatric side, there's good data out there, right? So we have a national audit, so each epilepsy service submits data to that, and they ask about transition. So we know that each service has a way of doing it. But like we were saying earlier, there's a difference between this gradual process that goes on for years, and it's like the gold standard and how we'd like it to be, versus the transfer of care, where you just have a one-off appointment, or even just a point at which you just say, you're not under us and now you're under the adult team. So those scenarios are very different, right? So the reality is it's really variable and patchy. And so I have a bit of oversight over the region where I work, rather than just the one service that I match to do my day-to-day clinics in. And we try and get information from all of those services, and hence we know that there's that variability in how it's done. And sometimes it's for good reasons, of this is just what works. We've spoken to the adult team and we know that this is a system that works better. And yeah, you have that framework that half the country uses, but we don't think that quite fits the people that we look after and the expertise that we've got in the service. Reality is often it's just scarcity of resource, so they don't have the right people in place. And as an example, in my patch, where the adult team just said we're putting a stop on transition, we can't do it this year, we actually don't have enough neurologists to do all the things that we have been doing. For one reason or another, somebody left, so the thing that they dropped, if you like, or put on hold, was transition. So that meant young people stayed in the pediatric service for longer, and suddenly they were becoming familiar with some of these different conversations that they weren't traditionally having. So that is not ideal, but that's an insight into the reality that's sometimes there. It should never be that a young person's left with nothing. I think that was the key I took from that situation. They still had their point of contact with the epilepsy nurse. They still were having conversations, hopefully, that had built on what had previously been discussed, and new things were coming into their life that maybe they were going to go away to university, and that wouldn't have been a conversation they normally have with their pediatrician. Now they had to, okay? And maybe the pediatrician didn't normally have that conversation, but they had to learn about it a bit. So these are the sorts of realities. I do think, again, from the sort of data that I've seen in my region, there is at least that transfer. So there's at least a kind of sharing of information between the pediatric side and then the adult side. That's kind of the worst case scenario that we tend to see. That's not perfect, so we try and improve it. But have you seen it?
So what I would
more
say,
real world?
well, not more real world, but I think I can honestly put my hand up and say that there aren't patches in our country where the patient is discharged to the GP from pediatrics. I think to actually universally say that never happens, I think would be difficult, because I think some areas they may not be the pediatric service, or they may be a pediatric service, but actually we don't have an adult neurologist or adult neurology service in every hospital, in every district hospital in the country. We may still have hospitals where you may have an adult neurologist visiting once a week from the main neuroscience centre. So, because the advantage in a way with pediatrics is you have the general paediatrician, and then you have the paediatrician with the interest in epilepsy, and then you have the paediatric neurologist. Whereas at adult neurology, you have your GP and you have your neurologist, and you don't have the general person that manages other things. So I think that's the worst case scenario, but I would very much hope that is diminishing rapidly. Okay, except for those who've remitted, who've come off medicines or seizure free for several years, and actually I don't think they necessarily need to go into the adult side, but anybody on medicines at that age should be transferred. So if we're thinking about the reality of what that can be, so again, we're currently faced at the Cambridge end more than the Peterborough end with a real sticking point to improving our transition. And actually, I think the worst case scenario is that those conversations, that preparation is not as broad and as informed as it needs to be. There is a conversation about transfer. You may not have a joint appointment, but there is an understanding that that transfer will happen. So at the moment, because we're stuck on resources, we're working hard on making sure the transfer destination is right, that we're all agreed where people should go. So at least that happens, even if we can't do the joint and we can't do the preparation. And then it's that you get a referral letter in on the adult side saying this person needs to continue on the adult side, and then you see them for the first time and you're then having those conversations for the first time. Not necessarily completely the first time, but to the depth that it's needed. So I think that's the issue. I think the other side from the adult, I would say, is I recognize that perhaps I pushed towards the aspirational because it's an interest for me and has been for a long time. Whereas you might have some adult services where it does become very medical. It's not so much focus on thinking about those transitions ahead of time. And it's that you go to transfer and it's great, right, your epilepsy, what your seizures doing, what's your meds doing? We'll see you in 6 months or a year. And those broader conversations. Because on the adult side, we have still got areas that don't have adult epilepsy nurses. And it is the adult epilepsy nurse that really forms the glue to that holistic approach, both for the young person, but actually also for the medical people. They bring that out. So I think that's where our gaps and challenges are. And I think one of the biggest challenges in all of this is that within the NHS, there is no structure, either at a commissioning level, so the people that decide on services, or where the services happen in hospital or the community, that jointly covers paediatrics and adults. That's the problem. They're seen as not just different departments in hospital, but even the kind of people who organise services, they don't do it together. They're seen very differently. And then the people who are responsible for looking at the whole area, you'll have different teams. There's not a team that oversights both. And that is for not just for epilepsy, it's for transition whole. And I think that's our biggest challenge and that gap, that there isn't a joint structure at all those levels.
Yeah, huge.
So my area where I live, the adult epilepsy nurse that sees me doesn't actually cover my area. They cover another area, and they added on my area because they can't afford to employ another nurse. So it's,
Stretched it out.
yeah, basically.
So, do you think, tell us what is meant by the term transition, and just try to tell the audience a little bit about why you think it's so important that it's done in a positive way?
Yeah. So from again, pediatric side, from my side, it's the it's an acknowledgement that an individual it's going to be different, right? So they are going to be at a different stage in life. They are going to need different things. Different things are going to be important to them, and so we need to mirror that in how we structure the service around them and prepare them for how things are going to be in a gradual way, ideally, so that things aren't a shock to the system, so that they aren't left unsupported.
And, adding to that as an adult, I mean, fundamentally, it's because the way our services are structured is that as young people grow up, they legally, and therefore that comes into services, you move from being a child to an adult. And you've got an adolescence in between, but actually from a service perspective, both for health and social care, it's children's services and adult services. And so the fact that a young person has had a condition like epilepsy before they became an adult means they're having to navigate moving from one side to the other, alongside the fact that their life experience and challenges and aspirations changes through that time. And so a good transition is really important to help that young person actually get the best for their health, because actually these things can impact how well their epilepsy is controlled, and that comes with risks. So recognizing that supporting people through that transfer is actually important for managing their health and the risks of not doing that, as well as good transition helps that person feel more control over their lives, what they want to do, and therefore make important decisions for them that are relevant to them. And that's what good transition does, is actually helping that person navigate not only their health, but actually their life and how that condition impacts on their health, so that they can then have realistic expectations, but also aspirations of what they can achieve. Because without that, I think this is such a critical age that they can lose opportunities, they can lose education, they can lose confidence and feel isolated. And so not only is that not good for their epilepsy, but that's not good for the person. And that's what we're trying to navigate and support. I think that's where it's really important. And that's what, the importance of trying to find the best way for that person.
Thank you to Sacha, Amit and Tejal for their valuable insights in today's podcast. And thank you to our listeners for tuning in. Remember, transitioning to adult services can be a complex journey, but with the right support and resources, you can navigate it confidently. Be sure to subscribe, and we'll see you next time for more conversations that matter.
Together we create possible.